Hello, everyone, and welcome to Exploring Mental Health, Community Voices, Scientific Insights Related to Modulators and What's to Come. My name is Jeremy Lane, and I'm the father of 4 children, 2 of which have CF. And I'll be moderating the session today, and we'll be introducing our other speakers in just a moment. But before I do, I wanted to do a couple housekeeping items. This session is being recorded and will be available after the event on the CF Foundation YouTube channel, and you'll be notified by email when the session recordings are available. We'll be taking questions from the audience throughout the session, and we'll answer them during the Q&A portion. We encourage you to submit your questions at any time into the chat box, and we won't be able to answer your questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. And we'll do our best to answer as many questions as possible. Before we begin, I want to remind everyone of our event conduct guidelines. Be considerate, open-minded, and respectful, and we ask that you do not use malicious or offensive speech and do not ask for or give medical advice. And if you feel the event conduct guidelines were violated, please contact a CF Foundation staff member at the help desk. There's also going to be a few polling questions from the panelists, which you'll be prompted to answer throughout the session. And these polling questions will help us get an idea of who everyone is and what you are excited to learn about today. Polls can be found on the right side of your screen next to the Q&A and chat. And finally, if you experience any technology problems during the session, you can visit the help desk in the expo area on the left-hand side of your screen. Now let's get started. This is the CF Foundation Standard Disclosure Statement, and you can learn more about the Foundation's interaction with industry at cff.org/industry. Here's our speaker disclosures. And now I'll pass it off to our first speaker.
Hi, everyone. I'm CJ Bathgate. I am a clinical health psychologist and research scientist and associate professor of medicine at National Jewish Health. I'm in Denver, Colorado, and I am vice chair of the CF Foundation's Prioritizing Research in Mental Health Working Group. We also call it PRIME. I'm a member of the Success for Therapies Research Consortium, or the STRC, and I am a program planning committee member of the North American CF Conference that happens every year. And I'm highly involved in mental health, so this topic is near and dear to my heart. I collaborate a lot with the Mental Health Advisory Committee here in North America, as well as the European CF Society, and my clinical and research expertise really spans mental health, stress management, sleep, and neurocognition across the lifespan across different life transitions, focusing specifically on adults, looking at family planning, lung transplant, new diagnoses, and looking at the relationship between mental health and CFTR modulator use.
Hey everybody, I'm David Fedele. I'm coming to you all from the East Coast. I'm in Jacksonville, Florida. A little bit different than CJ in terms of area of focus. I'm on the child family side as a pediatric psychologist. My institution is Nemours Children's Health in Jax, where I'm a principal research scientist here. And like CJ, I'm a member of the Foundation's PRIME group and also the Success with Therapies Research Consortium. And my research interests are focused on family functioning, adaptation, communication, coordinating sort of daily disease management responsibilities among family members in the context of a chronic health condition like cystic fibrosis. So excited to chat with you all today, hopefully get a lot of good questions and sort of conversation going, and I'm going to pass it along back to Jeremy.
And as I said, I'm Jeremy Lane. I'm the father of 4 kids, and 2 of which have cystic fibrosis. My kids have been on and off different modulators as we've looked at what works for them. One of my kids had some anxiety-related issues when she first started Trikafta a few years ago, which leads me into our first question. Are the people experiencing mental health changes? Are people experiencing mental health changes after starting a modulator? And we have 2 poll questions that are related to this, I believe.
So
The first
hopefully
one
you
is,
all should see a poll question. The first one would be, have you or your child experienced any positive mental health changes since starting a modulator? We know a lot of folks in the CF community have reported a lot of good changes in the context of modulators. And then a second poll question on the opposite side of if you've experienced any negative mental health changes since starting a modulator. So we'll give you a moment to fill those out, and then I think hopefully we'll be able to share those with the group here results to sort of just provide some context to our conversation tonight. I think we're going to share those in a second here, if everyone's had a chance to respond. There's the negative question. And so I'm able to see the results on my end. I'm not sure we'll be able to present those, but in the interest of time, what I could do is just sort of narrate what we're seeing, which really feeds nicely into sort of how we wanted to start the presentation tonight. So on the negative side, we had about 20 people vote. 68% said they did see, 60%, excuse me, said they did see a negative change. 12% said no, 16 said not eligible or not taking, and 12 not applicable. On the positive side, sort of a similar distribution, 57% yes, 23% no, and 10 each in not eligible or not taking. So thank you all for taking the time to fill out those answers, and that really fits with this question that Jeremy was asking. And as the results from our poll show, some of you have experienced or know someone who's experienced improvements in mental health, quality of life, what have you, after starting a modulator, and others have had the opposite experience. The findings that we have sort of as a small group tonight really fit well with some data that we're presenting right now in this conversation that basically asks the same broad question. So this is a study that was done 2 years ago, published in 2023, with over 700 people with CF who are taking a modulator. And the graph that you're seeing on your screen represents their perceptions of global changes since starting modulator therapy. To orient you to the figure, dark blue represents that someone feels much better in a domain. Light blue means somewhat better. Gray means no change. Pink means somewhat worse. And then red, red is how I see it at least, would mean that they're feeling much worse in that area. And so what you can see on this screen is a lot of all the colors, which is a really sort of good takeaway in terms of variability. So since starting modulator therapy, most people report better overall health, quality of life. The blue is bigger on the image than the other colors, I should say, in most domains. But responses are more mixed in some areas, especially when you think about social well-being, mental well-being, daily life needs, those areas of that were surveyed in this study. There you see that you do have a notable proportion of people who reported worsening in those areas of their lives. And so taken together, this slide, like our poll, shows sort of a few things. First, if you're one of the individuals who said, yeah, I have either personally or have a child or a loved one who's experienced some negative changes in context of modulators, you're not alone. And second, it shows that there's a lot of variability amongst your individuals that you know with CF or your local communities in terms of how people have responded in the context of modulators. That's also what we're seeing reflected in studies. Okay, so I'm going to pass it back to Jeremy for our next question.
Yeah, so our next question is, when did it become clear that there may be a connection between modulators and mental health changes? And to help answer that question, I'm going to bring up CJ Bathgate.
So one of the things that became very clear was when Trikafta came out, and there's kind of a caveat as we talk about this, is Trikafta is also known as elexacaftor, tezacaftor, ivacaftor, which is a mouthful, and so a lot of times you'll hear us refer to it as ETI. And so whenever you see ETI on the screen, or whenever you hear us say ETI, I want you to think about that we're also talking about Trikafta. So in 2019, at the end of 2019, ETI came out, and in about 2020, 2021, I really started to notice an increased dialogue about modulators and mental health. Now, I come from a very large center. We see upwards of 500 to 600 people a year. Some of them are second opinions, some of them are our regulars. So it's really neat to be able to see a large group of people come through, because sometimes we get to see signals of what might be going on, as compared to maybe a smaller site that has a smaller sample of people. We started seeing more presentations about modulators and mental health at the North American CF conference, and the Mental Health Advisory Committee, they did a big research prioritization survey among providers and community members. And they asked them, what topics do they think are going to be most important? And what I thought was really interesting was, there were a lot of spaces where providers and community members were aligned, but there were some spaces where community members were like, no, this is going to be a priority. And the providers were saying, oh, we don't really think this is going to be a priority. And what's interesting, and what always seems to be the case, is the community members are always right. You guys are always right. And that is why we love collaborating with you guys, because early on in 2020 and 2021, you guys said, we think we need to prioritize CF medication and mental health and like the interaction between the two. So you guys were way ahead of the curve on that. And survivor's guilt. And I think that relates a lot to perhaps even people that have access to the medication compared to those that might not. So then in 2023, the CF Foundation sanctioned PRIME's formation. And so here's a picture of all the individuals that are on PRIME. And I really want to highlight the top row, with the exception of our chair on the left, Anna Georgiopoulos. Everybody in the top row is probably somebody that's sitting in the audience right now, which is amazing. So hello to you guys. These are our community members. They make up just as much of PRIME as the people that are scientific researchers and clinicians. And the mission of PRIME is to advance our knowledge of mental health conditions in the CF population throughout the lifespan, and to promote clinical and translational research that will improve the understanding, prevention, diagnosis, and treatment of mental health concerns in CF. And so what I love about having community members on PRIME is they help us design research studies, they help us with ideas, they make sure that we're targeting things that are actually important, they make sure that we stay on track with what is needed. And they make sure that when we are asking questions, when we are doing things, that it feels accessible to people with CF and the caregivers. And it's just such a delight to have them on there. So every couple of years, we do put out a request for application. So if this is ever something that you guys are interested in when you're listening to talks like this, consider joining. And then that brings us here to today, where I really see mental health being brought up as part of routine care. You probably hear about it, I hope, in your clinics when you go and visit, whether you're doing quarterly or whether you're doing a little bit less, you should be getting some mental health screenings just to kind of get a read on how things are going. And there's really a lot of continued efforts by the foundation and researchers to incorporate mental health into various aspects of research and research outcomes.
Our next question is, when Prime was formed, what was one of its first priorities?
All right, so that's back to me. When Prime was formed, one of the first initiatives we took on as a team was looking at the scientific literature to really try to answer this question about if there was a link between ETI and mental health, and then secondarily, once we had sort of a state of the science view of what's out there in the literature, to try to help set sort of a research agenda for the next 5 or so years on this topic. So as we saw at the beginning of the presentation, for those who were able to answer the poll, and some previous data, a lot of individuals in the CF community are experiencing really remarkable benefits of beginning ETI, or depending on domain, don't experience any new mental health symptoms or worsening in the context of ETI. However, a common theme that we found in our review from case reports, which are really, think of those as more of summaries of specific experiences a given person with CF is reporting to have, and studies from single CF centers. We're sort of starting to coalesce around this idea that there was a subset of individuals with CF who were reporting new or worsening mental health symptoms in the context of ETI. And what we found in our review is that some of those common symptoms or changes that were reported included things like increases or new symptoms of depression or sadness, higher worries or anxiety, brain fog, or think of like feeling sort of sluggish cognitively, difficulties falling and staying asleep, changes in behavior, especially amongst kids, like less ability to manage emotions or acting out. Interestingly, the literature was also pointing to that there were improvements in some of these case reports or single center studies that happened in the context of either altering the dose of ETI or discontinuing it. At the same time, though, a big takeaway for us as a group was we have a ton of unknowns in this space. So, sort of walking you through these images that you see on the screen. First, one of the big unknowns is sort of the mechanisms or the reasons why we're seeing this variability or these side effects or changes, I should say, in individuals starting ETI or on ETI. So first, one main takeaway, I should say, was that it would be really helpful to understand why some individuals report changes in mental health and others don't. So we're trying to address this as a research community, in several ways. Two of the ways to highlight at this sort of more granular level is first, there are a lot of ongoing preclinical studies that involve mice or other animal models that are looking at mechanisms between modulators and changes in behavior or brain functioning in those animals. Second, there's some pretty cool pharmacokinetic or pharmacodynamic studies that look at what the body does to a drug, like metabolize it, absorb it, and the effect of the drug on the body, like through blood or tissue concentrations. So those studies are ongoing, and we'll talk a little bit more about those in a moment. Another takeaway was from a study design perspective, unfortunately and understandably, I think at sort of early stage research pipeline, a lot of the studies that included individuals with CF weren't done prospectively, meaning that the studies often asked individuals with CF to sort of look back in time, or their family members to look back in time and retrospectively report on how things change for them over time, which we know might be less accurate than if we looked at change prospectively moving forward. Compared to the adult studies, the pediatric group was pretty underrepresented at the time that we did this literature review. So we know generally, I would say, with reasonable confidence, less about mental health changes in kids and teens. We're working to change that, which we'll talk about at the end today. And this can be especially challenging because of those of you all who are caregivers or can think back to that time. Then there's a lot of developmental changes in relationship to mood and behavior and growth and all sorts of things that are happening during the child and teen years that affect behavior, sleep, cognition, etc. And then finally, sort of a thorn in our side with this whole area is that as ETI was rolling out, it was also COVID, sort of peak beginning COVID times, as you all, I'm sure, recall. So that's a big confound or sort of third variable in the equation for these studies, where we have a lot of questions as a research community, scientific community about are some of these changes that are being reported, are they potentially related at that time, at least, to changes that were happening for individuals with CF in the context of COVID. Okay, so I'm going to pass it back to CJ to give a little bit more detail about some of those mechanistic studies.
Okay, so now I get to geek out on the brain. And before I promise you guys aren't going to fall asleep to this, and it's going to be exciting. So there's some new basic science research, and I'm not a basic science researcher, so I had to deep dive into this to understand this, and it was really interesting. So basic science research was using rats and modulators, and this came out last year, and I think this is really relevant to this conversation. And before I share the results, I want to set the stage, and I want to orient you to how the brain works with a little Brain 101 so that we can better understand the findings. So I want you to think about your brain as a big circuit board filled with neurons. And neurons are brain cells that talk to each other. So everything that your brain does, all of our thoughts, our feelings, our experiences happen because our neurons are having conversations. And neurons remain quiet until they receive enough information to pass it along to its neighbor, and they fire in what's called an all or nothing manner. And so I like to think about a neuron like that big bucket of water that you might see hanging overhead at a water park. And this is actually a water park in Colorado. So if anybody is here from Colorado, this is just south of Denver. And this is where there's this trickle of water that dumps into this bucket. And then eventually, no matter what happens, once that water bucket fills up, it's going to tip over and it's going to spill all the water out and like completely soak the people that are below. So the process of filling that bucket up and eventually tipping over relates to what we call action potentials. And so these are those bursts of electrical activity within a neuron that result in a message being sent from one neuron to its neighbors via neurotransmitters. And so when we introduce medications into the body, they can actually change the way that our neurons work. And so some medications can really excite neurons. So what that means is they can create more action potentials and chatter between neural neighbors. On the other hand, there's medications that might be inhibitory, and they might inhibit the neurons, which creates a more slowed or non-communicative pattern between neural neighbors. So when we look at the research that came out, So this is from Dr. Daniel DeVore's group out of the University of Pittsburgh. They used rats, and they used different doses of ETI, which, as you recall, is Trikafta. And they also used the newest modulator, vanzacaftor, tezacaftor, deutivacaftor, which you may know as Alyftrek. We will also be using the abbreviation VTD for that new modulator. So they looked at ETI and VTD in rats at different doses, and they examined the neural activity in the hippocampal region in the brain. So you can see in this picture, this mock-up of the brain, and that little like blue piece, that's the hippocampus. And the hippocampus is really responsible for where we form our memories and where memory retrieval happens. And what they found was for both medications in rats was that these medications slowed the action potentials. So what that means is the neural activity in the hippocampus was inhibited. So after seeing this, my mind, since I work with people, immediately went into translational science mode. And when we had Dr. DeVore on a call, I raised my hand and immediately asked, could what's happening in rats be related to the neurocognitive changes that we've heard about in this subset of patients, right? People that are experiencing brain fog, memory trouble, word finding difficulties, things that we might associate with the hippocampus. And his answer was, we're not sure. And the answer is it's not linear, right? Because the rat brains and human brains are not the same. It's not a one-to-one correlation, but it is a very good start. And this study does give us food for thought. And I hope it will encourage more basic science and more clinical translational work in this area, because we really don't know a lot about this. And so this is really an opportunity for scientists and researchers from different backgrounds to collaborate and use their expertise to figure out a question that the community is really interested in finding out. I'm going to kick it back to
Yeah, so this is actually a question that I had because I have two kids with CF. They both have tried Trikafta at different points. And my daughter had some anxiety issues sort of that I felt were linked to that. And my son has had no issues with it at all. So the question is, why do some people experience mental health side effects and some people don't?
Okay, so I'm going to try to field this one. It is a great question and one we hear quite often, understandably, in the CF community, and maybe a little bit of that, like looking through the chat, the Q&A, where people are also talking about their children and the varied experiences they are having. So absolutely, it is not a one-size-fits-all sort of answer. So the unfortunate answer that we have to date is really sort of it depends is kind of the best we can capture it, with hopefully some more insight as additional data and studies are done. But the studies to date make it pretty clear that there is this distribution of sort of responses amongst people that have report experiencing mental or behavioral health changes in the context of ETI. And a paper that came out a couple of years ago did a really nice job of synthesizing why there might be potential reasons for these individual differences in the community. So they put them into 4 different buckets that I'll walk us through tonight. And you could then reflect on your own experience and see whether this might be related to what, if you resonate with one of these or not. It's probably way bigger than 4, but is a good starting point for us to sort of talk through. So the first hypothesis that we have as a community is it is possible, just like CJ was mentioning, in those preclinical studies, the ETI is having a direct impact on functioning of the brain for some people, especially since we know that these medications cross the blood-brain barrier. And this could explain why we're seeing reports of things like brain fog, changes in how people are experiencing hunger cues, etc. Second, it's possible that individuals who have started to take ETI are experiencing what we think of as changes in their psychological state. We alluded to this earlier, but individuals with CF could experience more, I think we might sort of characterize them as existential crises in the context of a new medication that we know has these sort of life-altering or health-altering changes in regards to their health, life course, etc. So examples that we've heard in clinic amongst our centers would be, unfortunately, some regret over past changes, past behavior, so like not saving for retirement over time, uncertainty about what this sort of new life course might mean for them as an individual with CF. We did mention survivor's guilt earlier. And that could be related, of course. Those sorts of things could cluster with changes like increased worries, sadness, or sleep difficulties. Third, we don't have a comprehensive understanding yet of drug interactions between ETI and other medications that individuals are taking. So we do know that ETI shares metabolic pathways with commonly prescribed SSRIs. And there is some indication that individuals who have a previous history of a mental health condition might have some degree of additional risk around than reported changes in the context of ETI, depending upon study that you're reading. And finally, it's, of course, the null hypothesis here. It's possible that there's no association between ETI and mental health for some individuals. So in these instances, it might be that there's other factors that were happening concurrently or are happening concurrently. We talked about COVID. There could be significant life stressors that are going on during those times as well, and would be difficult to then have sort of a causal attribution about change. So we do have a poll question. We can see this is a little bit easier to distribute since it's just one. So I hope that we can present the poll to you all. But our question is, thinking back to the beginning of the presentation, I think about half to two-thirds of you all indicated that you experienced either a positive or a negative or a loved one change in the context of a modulator. Thinking about these hypotheses, which category do you feel might best represent your experience or your loved one's experience? And I think I can give people a moment to answer that, and then I'll be able to share the results to see if we have any particular tilt in one direction or the other. Give people about 10 more seconds. Okay. So we have, I think just walking people through what I can see on my screen at least, we're seeing about a quarter of people saying that there's no association, about a fifth saying that there's a change in sort of psychological state, sort of other things related to the effect of the medication on just future life, and then about half saying a direct effect on the brain. So that's really interesting information for us to consider too on the research side. So thank you all for taking the time to answer that. Okay, and I'm going to hand it back over to Jeremy so we can start thinking.
Yeah, so our next question is, if I have a concern about my own or my child's mental health, what should I say to my CF team? This question is a little bit, or I can relate to this question a lot because when my daughter first started on a modulator, I was looking at several things that I thought might be causing anxiety. I was wondering if it was maybe different things that were happening in her life, or if it was related to COVID, or if it was related to the medication. So thinking through all of that, what I decided to do was mention the sudden anxiety to her CF team. And for a little bit, we kind of went back and forth trying to manage the anxiety just to see if we could kind of stay on top of it. But my gut instinct was sort of telling me as a parent that this was definitely related to the medication. So I just mentioned that to her doctors, and what we kind of decided together was that her physical health was good enough that we should go ahead and discontinue the modulator for now, and then just kind of keep an eye on it and see where we would go from there. And since then, she's actually started Alyftrek and has had no issues with that one. So I think it's sort of, from my experience, it's just keeping the lines of communication open with the doctor, and then finding a path forward that works best for your situation. And I think CJ probably has some things to say on that as well.
Yeah, I think going to your doctor is amazing. I think some people might feel comfortable with another team member too. We all work together, so maybe you have a really great relationship with like a nurse on the team, or maybe it's your team psychologist or the social worker, or maybe it's the respiratory therapist. I think it's just bringing it up with anybody and just saying like, this feels a little off. Like, what do you think, or who should I talk to? I think just bringing it up to anyone is great. And as long as you feel comfortable, and hopefully there's somebody on your team that you feel comfortable saying something to. And that kind of goes into our next question.
And that is, if I have a concern about my own or my child's mental health, what other resources are there?
All right, and I'm going to take that one. So just to amplify CJ's comments, obviously to the extent you're comfortable starting with your own CF team who knows you well and knows your family well, especially you're identified, if you have one in terms of mental health coordinator, that could be social worker, psychologist as part of your team. It's a great place to start. In addition, there's some resources that we thought you all might be interested in having. First, we're going to provide a link, hopefully in the chat, for caregivers from the American Academy of Child and Adolescent Psychiatry, that outlines when you might think about seeking mental health services for your child. So that's a common question that I get in my clinical practice in terms of, hey, do you think this is concerning? Do you think this means that we should maybe seek some external help? So that can be sort of a starting point to answering that question for you all. And second, there's a link from the CF Foundation specifically about how you can go about finding a mental health professional, and does a really nice job, I think, of describing what you might expect from mental health services. We're getting better as a society in general, but there's still quite a bit of stigma out there, depending upon community and individual, around mental health and what that means and what it's like. So it does a nice job of demystifying that. And also, we thought it'd be helpful to provide a link to Psychology Today. This provides a way for you to do sort of a local search for mental health providers in your area. You can look by background, focus of practice, etc. It might be good to reconcile that with your insurance provider and who might be covered, etc. Of course, but is a nice a sort of one-stop shop to at least get a lay of the land on who might be available in your area. And then I think CJ was going to chat a little bit about some therapist-led interventions.
Yeah, so there's also some therapist-led interventions that your mental health coordinator, psychologist, or social worker at your center may be trained in. And so one of them is the Coping and Learning to Manage Stress in CF program, which is called CALM. This was an intervention that I designed, so I can speak at length about it, but I'm just going to talk about it very briefly. So this was tested in a geographically diverse large sample of adults with CF with mild to severe anxiety or depression symptoms. And after 6 telehealth sessions, when we compared a group that received CALM compared to a group that was on a wait list who didn't receive CALM, the group that did receive the CALM program reported significant reductions in depression and anxiety, improvements in their ability to cope, and reductions in stress. And so really the focus in this program was exploring the mind-body connection, relaxation training, linking thoughts, emotions, behaviors, how all those work together, self-care, how to fuel your body with food and movement, what to do when you've done the thought work, and how to cope with kind of the aftermath of that when it still remains. So problem and emotion focused coping and setting realistic goals. And so there's also other programs out there besides CALM that are established. So there's CF-CBT and ACT with CF, which stands for Acceptance and Commitment Therapy with CF. I mentioned these programs because these are tested and designed specifically for persons with CF. There are also many other modalities that are used in the general community that would work great, I think, with caregivers or persons with CF. They just haven't been tested specifically in this population, but I don't see any reason why they wouldn't work. So these are all really great options to explore with your team's psychosocial providers if that's something that you're interested in. And, you know, research does support that if you are experiencing symptoms, like the gold standard is medication and some sort of therapeutic intervention, but sometimes people have different thoughts and feelings about one or the other. Maybe it's a time constraint and they'd rather hop on a medication, or maybe it's, I don't want to put another medication in my body and I would rather, you know, go see a therapist and talk about some of these other things and have more long lasting effects. So it's really based on whatever your preference is. And that leads us to the next question.
Yeah, and that question is, what are we doing now? It seems like there's a lot of resources out there for mental health now, but what other studies are happening or in the works around mental health?
So the newest modulator that is out there, the vanzacaftor, tezacaftor, deutivacaftor, which I've abbreviated here, VTD or Alyftrek. This came out very recently at the end of last year, available at the beginning of this year, as an alternative to ETI. This is a once-a-day modulator. And the clinical trials showed a non-inferiority in lung functioning between VTD and ETI, which means that there was no significant difference in changes in FEV1, whether someone was taking ETI or VTD, but there was a significant improvement in sweat chloride for those that took VTD. So I think a benefit of VTD is that it's dosed once a day. So that could be a real benefit for people, right? If they don't like the twice a day dosing. And of course, if for some reason someone didn't do well on ETI, it's a different drug. And so that might be worth pursuing as well. One thing, though, that we did notice is when the clinical trials were happening with VTD, in order to be part of that study, the VTD clinical trial participants were required to be stable on a full dose of ETI. And so what that meant was that sample that they were testing this on excluded persons with CF that had either modified or discontinued their ETI due to mental health or liver-related injury. And so the key clinical questions that we had as researchers, and that really came to us from the community, were when we look at that group of folks that maybe came off ETI, whether they reduced their dose, they flipped their dose around from morning to evening, or they had to discontinue because of mental health reasons or liver-related reasons. The questions that came from the community are like, how likely is it that I'm going to tolerate VTD if I start this? Or, you know, am I at elevated risk for similar side effects if I had them on ETI? And these are questions that we are seeking to answer in our newest study that is just hot off the press launching, called ReTrial. And ReTrial stands for Restarting Triple Therapy with Robust Monitoring for Adverse Events. And you know that it can't be a CF study without a great acronym. So ReTrial was really fitting for this. And this is a multi-site prospective study. So David had talked earlier about how a lot of the literature that we have on ETI is retrospective, right? We're asking people to, like, hey, remember when you started taking this, like what happened? Or we're looking at chart reviews, or we're looking at what happened in the past, as opposed to like getting some pre-data and then seeing what happens as we follow someone. So what's cool is this is a prospective study. It's observational, which means the clinical team is still going to have full control over what's happening with the people in the study. We're just going to be observing looking at our different outcomes of what happens when people with CF ages 6 and up that start VTD who previously experienced mental health neurocognitive, sleep, or liver injury on ETI that resulted in some sort of modification or discontinuation of standard dosing, what happens? And so listed here are the investigators on the study. And this is also being run through the STRC that's helping with all of our study and data management, which is no small undertaking. They have been amazing at collaborating with us and getting everything that we need in a very short amount of time. And so it's been a delight to work with the STRC, and there's no way we could have launched this study without them. So the retrial sites, you'll see are listed here. There are 15 different sites, and these sites were selected based on the size of their eligible population, geographic diversity, and site involvement in sub-studies and different ancillary studies that are going on. And so right now we are recruiting specifically out of those sites. So if you are somebody listening to today's presentation, you're like, oh my gosh, that's one of my sites, I want to be a part of this, absolutely go talk to your team. Like, they are most likely in the process, in the end stages of being able to launch the study and offer this to you. And I strongly encourage, if you have interest in this, if you sound like one of those people, or you have been one of those people that experience any sort of mental health or liver related change when you were on Trikafta and you want to try something new, with full control with your clinical team over what happens with it, but you want to have some enhanced monitoring, retrials the study for you. So what this looks like in a very high level overview is there's going to be two major arms. There's going to be retrial mental health, which we're going to have 150 people in. We're going to be collecting mental health surveys and doing some daily diaries. And then there's going to be a liver arm, which these are people that had drug-induced liver injury when they were on ETI, and this is going to be a group of about 50. Anybody that is in the mental health or the liver arm will be eligible to opt into retrial bio, which is going to be a biobanking portion of the study where you can opt into providing pre-post samples of blood, stool, or nasal swabs, but by no means do you have to. This is optional, and of course you get paid for all the different things that you are providing, because we really value your time and your input and your contributions to science, because we can't do this without you. There'll be a subset of the retrial mental health group that can serve as a control group for the liver arm, that they have to have had no liver related concerns so that we can compare and contrast those groups. And then there's also going to be a subset of the retrial mental health arm that if you had any sort of brain fog or kind of neurocognitive related issue, right? Word finding difficulties, kind of like what I'm having in this moment right now. I'm like, what are all the other neurocognitive things? Trouble concentrating, those types of things. You would be eligible for retrial neuro, and this is going to be pre-post neurocognitive testing. And this isn't just asking you, like, are you experiencing brain fog? This is going to be performance-based testing based on NIH, National Institute of Health batteries of tests that you can take. And this will be for ages 7 and up, because that's what the tests are normed for. And so really cool opportunities for people to be able to do this study. And this study was really born out of the community saying, hey, we think there's something going on with ETI. And as researchers, we are not able to say definitively without the science backing it what's going on. So the better the research study that we can design, the better results that we can provide to people, and kind of the better data that we can share with you guys and be able to answer your questions. So if this is of interest to you and you are at one of those sites, I strongly encourage you to talk to your team, because this is a real opportunity to give back to this amazing community that you are a part of. All right, I'm going to turn it over to David, who hopefully will not have neurocognitive challenges remembering what they're going to say on the slide.
That was great. Okay, so switching gears just a little bit, another sort of like what's happening right now, sort of breaking news uh, type of thing is TIDES 2.0. So this is a study that's just getting started. It's in its first year of funding from the CF Foundation, and the focus of TIDES 2.0 is on better understanding how common depression, anxiety, and behavioral problems are in kids with CF under 12 years of age. So this is a follow-up to the original TIDES, TIDES 1.0, I guess you call it, which assess rates of depression and anxiety in teens with CF, adults with CF, and parent caregivers of individuals with CF. And that was really the catalyst to all of this mental health screening that's happening in CF centers now. So it really changed the landscape of mental and behavioral health in CF that the original TIDE study did. But it was only for 12 and up. And really here, what we're doing is we're moving the focus to the younger age range. So we can think about developing more targeted treatments, understanding lay of the land for this important swath of the population. So really quickly, the TIDES 2.0 study has three overarching aims. The big one is prevalence, or you can think about that as occurrence of mental or behavioral health concerns in 600 children with CF ages 18 months through 11 years of age. A cool secondary aim here is to identify the best screener for these symptoms in this demographic. So the TIDES group selected the pediatric symptom checklist and the PROMISE measures. PROMISE is a National Institutes of Health created or funded initiative to develop really strong surveys of patient-reported outcomes like depression, anxiety, those sorts of things. Both of these are freely available, is the important sort of upshot of this. And so the TIDES team is really interested in focusing on which of these two measures might be the most useful for future screening. And then aim three, which I'm more squarely involved with in the study team, is focused on qualitative data collection, where we're really, related to this presentation, trying to get a better idea of characterizing changes that families are reporting their kids are having in the context of starting modulators. Here's a map of the participating CF centers. And so you have the PIs of this study at the top there, Dr. Smith and Quintner, who are at Buffalo, and Joe DiMaggio, Anna Georgiopoulos at Mass Gen, and Michael Schechter at VCU. The data is being collected at Brown and then in Providence, Rhode Island. But you can see there's really good distribution of these sites. There's 16 across the US. So hopefully some of you are seeing your center represented there and would be interested in participating. And like I mentioned before, 600 individuals. We're hoping to equally split those between 18 months to 6 years and then 6 to 11. Developmentally, that kind of makes sense to us. And also that's the way sort of the measures are developed. We are, just to sort of spotlight this, really interested in oversampling minoritized communities, broadly defined. And what that means is we are recruiting a higher proportion of those individuals based on our interest in really wanting to promote equity in our in this study and also within CF research more broadly. And like I mentioned before, a nice, I think, outcome of this study will be some insights into which screening we might want to support moving forward for this space. And we're hoping to really get some great information from families in our qualitative follow-up interviews. And so for those families who report that they have an experience, a negative experience in regards to mental or behavioral health after starting a modulator, we're going to invite 60 of those or more if needed to do interviews with us after the study is finished, really trying to get their experiences of what happened, when do they notice changes in their child's mental health, how severe were those changes, how did it impact their day-to-day functioning, what do they think caused some of those changes, how did they manage them, did they discuss them with their team, so on and so forth. We are also going to be interested in looking to see whether there are gender differences between boys and girls in those types of reports. And our goal here is to really just have a more comprehensive understanding. Going way back to the beginning of tonight, we were talking about how we really don't know a lot about the pediatric subset. Unfortunately, in this study will be really, really helpful in answering those questions. So just to spotlight this one, like CJ did, if you're part of a center who's participating in TIDES and want to know more, I'm sure they'd be happy to chat with you about it. We are all getting our local IRB approvals to be able to do the study and making sure that we're doing everything appropriate in terms of human subjects protections and all of that. But data collection should get started very soon. Okay, so I think next up we have time for questions.
Yeah, so it looks like we have several questions in the chat, so I'll just start kind of working through those first. The first one is maybe a summary of what do we know to date regarding exactly how CFTR affects mental health.
Yeah, I know that question came from Joyce. It looks like at the beginning of the talk. Joyce, I'm hoping that, or Suzanne, excuse me, I was reading your name backwards. I'm hoping that we have a little bit better of an idea after our talk today. I think the answer is we know a little bit. My take, I don't know what you would say, CJ. We know a little bit, but not enough, not nearly enough. And an important takeaway from my perspective of tonight is that the foundation has heard that message loud and clear. We as the scientific community and clinical community has heard that message loud and clear. And we're trying as quickly and efficiently as possible to answer those questions, but it's I'm sure not fast enough. So there's a lot of individual, I think, variability in how people are responding and experiencing changes. And I think an important take home as well is if you are an individual who is having some questions about mental or behavioral health while on a modulator or not, then bringing that to your CF team as a point of discussion would be, I think they would be open to it and also be really interested in learning more about that experience.
Then it looks like the next question is, what do we know so far about mental health issues on Alyftrek versus Trikafta? So I guess comparison between the two.
I don't think we know a whole lot. I think that's why we're doing a huge part of why we're doing retrial, right? When they published the data on Alyftrek, right, this is on a sample of individuals that were able to take a full standard dose, presumably were not experiencing a lot of those mental health challenges that cause people to reduce or modify or discontinue. So yeah, we don't really know. And so that's why we're doing this. And I did want to clarify from some of the chat. Somebody asked about travel. A lot of this is done virtually. So all the surveys are done virtually. We do need pre-post blood draws, but you will presumably be getting these clinically because the recommendations are to get blood draws monthly for the first 6 months, and you should always get a pre-blood draw so that you have a comparison to see what is it like before and after. The neuro tests are in person, so that would be a drawback if you might not be able to do that, let's say, if you live hours and hours away from your center. But if you're somebody that comes in for your appointments, you could tack the neuro testing onto one of your appointments if it works out with timing. So I think it's just close collaboration with your research coordinator. And I also, just one other thing that I get a question a lot about, we're as the study team, we are not telling you or your clinical team what to do or how to modify or any suggestions about what you should do with VTD once you're on it. So you don't have to be on it for a year. If you try VTD and you don't like it and you want to modify, or you want to go back to ETI, or you don't want to be on a modulator at all, like, that's fine. You can still be in the study. We are just observing what happens. And so I think that's nice for people to know that this isn't a clinical trial in the sense that, you have to do a certain thing with the drug. We are just observing what happens when you are, how you are taking the drug, right? When you're taking it, how you're taking it, what you're doing.
Okay, and then it looks like next question is, you mentioned survivor's guilt in relation to modulator eligible patients. I have a daughter who is really struggling in that sense. What do we know, and what or how is it being talked about, etc.?
I could maybe start, CJ, and then
Go ahead.
yeah. So great question. We don't know scientifically. We don't know a whole lot. So the data that I've seen on that experience is mostly from qualitative interviews. So people are sort of describing their experience post modulator. It is being reported. It is something that's out there, and a real experience, and a real thing people are struggling with. And I think one of the sort of upshots of that within the clinical community has been recognizing that it's a concern, being hopefully more open to screening and sort of opening the door to conversation as people are starting modulators and have been on modulators, and might be experiencing these things. And hopefully downstream will be something that we think about including more systematically in our screening, along with medical traumatic stress and some of those things that we know can unfortunately happen for individuals with CF or their loved ones.
I agree with that, and would piggyback on the medical traumatic stress. I think that is really linked with survivor's guilt. A lot of the stories that have been shared with me are thinking about friends with CF that they've lost, that they just, they didn't have the opportunity to take the drug. I've also seen and heard about individuals that have friends that are not eligible for the drug, so they feel that guilt of like, why was I like chosen to have this genotype? Like, why can't they be chosen? And so I think there is a level of trauma associated with that and guilt associated with that you can work with a psychosocial provider on and tease that apart. And I think that's a absolutely acceptable thing to talk about in therapy, because it's a very real, very heavy thing to sit with. And any psychosocial provider that works in CF understands this and can hold that space for that individual to process that. So definitely something worth bringing up.
And the next question is, what impact does it have on the limbic system, and why does it seem like emotional volatility and emotional modulation are problematic ever since I started Trikafta 5 years ago?
So that's getting more into the brain. And I love that question, Mark. I think that we don't have specific studies that are targeting the amygdala, right? Looking at specific parts of the limbic system, looking from the basic science. I know that one of my colleagues, Leah Reznikov, does look at some amygdala related stuff and limbic related stuff related to its relationship with lung, but not necessarily with CFTR modulator. So I think that's a really unique space that somebody could do some research in. And again, it's one of those things, like, as researchers, like, when we think about like the pie of research that we can do, it's like, I know like this chunk of the pie, but like I don't know this other chunk of the pie. And so it's like finding those collaborators that can help shine light on that other part of the pie that I'm not an expert in, but I could give them this other slice that I could provide my expertise in. And I think that really ties into that kind of like the ups and downs that it seems like you're describing. That really is, I think, echoed in some of the research studies and qualitative work that we've been describing in some of these research studies, that we need more prospective studies to look at. And some of the more recent research out of Europe, the modal CF study, if you want to Google that, MODUL-CF, they actually looked at some behavioral changes in children when they were starting on ETI and showed some like emotional lability. So there is some research that's out there, but it doesn't necessarily tie it specifically to like, this is the brain region that it's being activated on.
Okay, and prior to CFTR modulators, were there studies on what CF patients were experiencing with mental health? And are there indicators that CFTR modulators are worsening those experiences?
So good question. There were quite a good amount of studies that would describe frequency of mental behavioral health concerns in individuals with CF, kids, adults, what have you. One of the big ones that I mentioned before was TIDES, which was an international study that led by Alexandra Quittner, who was focused on depression and anxiety specifically, and found that individuals with CF were several times more likely to to have symptoms that would indicate risk for the diagnosis of depression or anxiety. What we don't know, though, so that's pretty well established that there was higher likelihood of mental health concerns within the CF community. What we don't really know is how that, with much detail, is how that has shifted in the context of modulators. There are many that say things have improved, and there are many who would say that things have decreased in some areas, right? And so with retrial, with TIDES 2.0, with some of these other studies that are going on internationally, we're hoping to be able to provide better answers to that. Because I think in the clinic, families would come in and say, my kid's doing fine right now on the mental health side. And I'm reading that there are individuals who then start these medications and are reporting changes like, what should I do? What's my risk? And it's really sort of a tailored conversation I would encourage you to sort of think through with your CF team and closely monitor changes if you're seeing them to happen.
Related to that, there's also been some systematic reviews, which are basically a collection. It's like a group of researchers that decide to look at a bunch of research studies in a certain area and like put all the data together. And they looked at ADHD in CF, and they found that persons with CF were 2 to 3 times more likely to have actually ADHD symptoms. It was very similar to like the breakdown of anxiety and depression. And so that to me made a lot of sense, because it's not really surprising given the challenges of having a chronic illness and everything that goes along with that layered on top of daily living. So like there are things that are, I think, unique to this population that may have nothing to do with modulators and everything to do with taking care of and like living a life with CF too. So I think that's important to factor in when we're thinking of this idea of like prior to CFTR modulators. I mean, it may be related to the modulator, it may not be related to the modulator.
That sort of plays into the next question of CF patients often have a lot of trauma and other issues going on from their experiences struggling with the disease. What are some insights that people are struggling with, or what are some insights that people are struggling with most, and how are they helping it?
Well, I just want to acknowledge for anyone out there that has experienced medical trauma, there are so many procedures that you go through, right? Like poking, prodding, routine labs, CT scans, exacerbations, all your tune-ups, all these things. Like there are so many touch points that are happening with providers that it is not uncommon for medical traumatic stress to happen. So you are not alone in feeling like, having this heightened sense of anxiety, like when you look at the doors of your CF center or the hospital. And so, there are more touch points that happen and things don't always go as planned. And so it's highly emotional. And so if you feel like you're having that kind of stress, you should definitely talk to your psychologist or social worker or some sort of mental health provider on your team. So I just want to put a plug in for that. I know that we are running out of time. I'm just like looking at the clock. And so I know we probably need to wrap up, but I just wanted to let you guys know that trauma is real and it is something that can be worked through. So if anybody's listening and feels like that's them, definitely talk to somebody on your team because it's something that we hear about a lot, but it's not talked about enough.
Okay, I think that's all the questions we have time for today. Thanks again, everyone, for your participation and great questions. Before you go, please fill out the satisfaction poll, which is under the poll tab on the right-hand side of your screen, right next to the sessions chat. There are many wonderful resources related to this discussion, including the slides from today in the resources document found on the reception page. Please spend some time exploring the resources and download anything that you want to keep. And thanks again.